Uh, Good morning to everyone at Hyderabad.
Yeah, please. Can you just
So,
go ahead
can
with
we
the
have the slide,
case?
please? Ashish, why don't you tell us?
Good morning, everyone. So here we have a 50-year-old gentleman. He is a doctor from Iraq, and he has risk factors of hypertension, impaired glucose tolerance, HbA1c of 6.2. He is a heavy smoker and obese. He came to us with complaints of angina for last 2 months, which was Canadian classification grade 3. His ECG showed QS complexes in V1 to V3, with echo revealing a regional wall motion abnormality in the LAD territory, the ejection fraction being 40%.
Can we have the runs, please? Incidentally, the gentleman had an angiogram done in Iraq, which had showed triple vessel disease, was advised CABG. But he declined, he wanted the percutaneous option, so he has come to India for treatment. So that's the RCA, it's a diffusely diseased small caliber vessel, which we will be tackling later. That's the left system. We see a distal left main disease, ostial LAD, proximal circumflex. And then we have a tight lesion in the mid LAD and a longish segment in the LAD. So we first wired the LAD and then pre-dilated the tight lesion with a 2.5 millimeter balloon. And then we took an IVUS run for both the LAD and the circumflex. So we show you the LAD run. So the LAD is actually diffusely diseased distally, difficult to find a landing point for the stent. But we identified an area just after a distal small septal, which could be a possible place where we could land the stent. And the sizes we got were left main body is around 5 millimeters. Prox LAD is around 4. And proximal circumflex is around 3.6, 3.5.
Can we interfere in 1
So
minute?
Sure.
See, it is actually a Medina 111 classification, prox, distal LMCA, LAD, and circumflex. Is it true? Correct. So now you did an IVUS only to the circumflex. Why you did not do an IVUS to the LAD to understand whether there is a calcium there, what is the size of the vessel? But you have
We have done the IVUS to LAD first and then to the circumflex.
So what was the IVUS MLA in this minimal lumen area as well as the vessel size of the LAD?
See, can we have the LAD? See, as I said, the distal LAD is diffusely diseased. There's a plaque all the way down. Difficult to find a landing spot for the stent, but we identified an area just after a small septal, which is relatively free of plaque, as you can see. And the size there of the vessel is around 2.3.
The distal LAD is 2.3. What is the proximal LAD? Proximal LAD.
Proximal LAD is around 4.1. Show the proximal LAD.
How much? How much?
The proximal LED is around 3.94.
But it is little more we are actually taken. I think it can be 3.5. Okay, 3.5, 3.6 millimeter will be there. And just it's a ostial part of the LED. How much is the size?
Ostial LED is 4.1 with a plaque burden of around 69%.
So your actually landing zone is a problem here because distal LED looks like very small, right?
Yeah, the distal LED. So we have identified a place. If you see on the angiogram, show the epicranial view.
Correct.
If you see the septal arising distally, a small septal, just after that, on the IVUS as well as angiographically, we are looking at an area where we could land the stent.
By angiographically, I'll tell you up to the diagonal there is disease, and just after the diagonal there is a minimal disease, which is actually I really don't know. You may be landing up a stent exactly up to the septal artery may be one size, from the septal to the diagonal or just distal
Yes.
to the diagonal will be another size. There are two stents to be used in LAD. If properly
Yeah,
thinking,
so-
3.5 in the proximal LAD, 2.5 to 2.75 in the distal LAD. And I don't know about what is the size of the circumflex. What is the size circumflex?
The circumflex is 3.5, 3.6, the proximal circumflex.
Okay.
Show the circumflex, please.
So
The IVUS.
your strategy in this case is
So
actually
what? Oh,
a dedicated bifurcation stenting. And what is the bifurcation stenting strategy here? You are planning for a DK crush, you are planning for a
We have
mini
a-
crush or a tap.
we are planning a tap.
Okay. So
A tap, a T with a minimal protrusion.
Tap is perfectly fine in that situation,
So,
I guess.
uh,
So you're
and,
planning any
and
debulking
we-
strategies too?
Yeah. Pardon?
You're planning on debulking strategies too, like cutting balloons or rota?
No, no. We have taken the IVUS runs and we have seen a little bit of calcium, nothing much. And so we are not doing any debulking. We have done a pre-dilatation to the tight lesion in LAD. And we have stented the distal LAD with a 2.5 38 millimeter stent, Zions Expedition. Show the stent, please.
but Sandhu actually
So-
by the vessel
So
look
that
like
was the,
Dr. Sandhu, actually the vessel look like you have to prepare the lesion well, especially in the proximal LAD. In this case, a rotablator is not required.
Yeah, proximal
but we require a cutting balloon to have a preparation of the vessel. I personally feel that cutting balloon will not cause that much dissection as the normal NC balloon. That is what is my perception. Whatever is your convenience and your thinking, you can do it.
I mean, I would like to use a cutting balloon if my normal balloon is not giving a good result.
Okay.
So we have taken a
Okay,
pre-dilatation,
it's
and after the
act- and
pre-dilatation,
it's
it was a very good.
Sure.
Yeah. Now what is the
So
size
that's
of the
the
stent you
position
have
of the
taken?
stent.
Now what is the size of the stent you have taken in the
That's a
proximal?
2.5. That's a 2.5 38 in the distal, and after we had deployed it there,
2.5 into 30. What is the size of the
then
length,
we
length
took
of the
another
stent? 28.
38 millimeters.
That is actually which make of the stent?
38. Zions Expedition.
Science expedition. Okay.
So after the deployment of the distal stent, we found that distal to the stent there was some spasm. We were contemplating on doing another IVUS, but later on after giving vasodilators, the distal spasm has improved. And then we have implanted a 3.5 23 millimeter Zions Expedition in the proximal LAD.
Distal vessel is
So
very small.
that's
so
where we are.
possibility
Give
of
me the left
dissection
main
should be ruled out.
And then what you call, we have deployed it at 18 atmospheres, the proximal stent, because as we said that the vessel size is nearing 4 millimeters in the prox LAD. So we have deployed the 3.5 stent at 18 atmospheres.
3.85.
And now we are deploying the left main stent, which is a 4 into 18 millimeter stent, Zions Expedition.
4 into 28, right? What is
18.
this? 18.
Our previous stent has reached almost the ostium of the LAD. And we need another 8 to 10 millimeters in the left main to do the port. So I think I need another 4-5 millimeters into the LAD. So we are taking a 4 into 18 millimeter stent.
So you took a 2.5 into
Any
28 in the
comments?
distal. No. Sandhu, can you explain? 2.5 into 28 stent distal LAD.
Yes.
In the mid part, what another stent you used? What is
No,
the size
sir.
of the stent?
No, sir. 2.5 into 38 millimeters in the distal LAD.
Okay.
3.5 into 23 in the proximal LAD.
Okay. Then what is the next? Next
And a
what is
418 now.
the- Correct. Now you used a 2.5
Now it's a
into
418
38. No.
millimeter stent.
Let me tell. 2.5 into 38, 3.5 into 23. Now you are planning to take a 4 into 18. Correct?
Right, sir.
Correct. Okay. Now after that you are planning for a tap into the
we
circumflex
just-
and make it. Okay.
Right, sir. Absolutely. We are just, I think we'll come back a bit. We are too much into the LAD.
So you are putting a stent from the left main to the LAD you are thinking that you may get a 8 millimeter into the LMCA to do a pot, right?
Yeah, around 10. 10, sir.
Okay,
Yeah, I think I'll get around 10 in the left main.
Okay, I don't know whether it's 18 will do that. I don't know.
I think we are too much into. Can we
Little
have a
longer
little
will
bit
be
of a
ideal,
boost,
I think.
please? Yeah. We'll just see. We'll change it. Otherwise, we have a 23 millimeters also. We'll just have a boost and see. We are too much in the LED. Yeah. Okay.
Are you showing us 10 boost to understand what is the?
Yeah.
Could not see.
Yeah. I just want to have a minimal overlap so that I can have an adequate length in the left main.
Advantage of the actually science expedition is actually the marker is the point of the junction. Marker is up to the marker there is a stent, so there is no issues there.
Yeah.
Stand boost.
Yeah. I think we are good at this position. We just have a short. Yeah. We are good.
We are
huh?
good. We are good.
Just
I
give me a
think you will
little
get
bit of,
10 to
external.
11 millimeters in the LMCA minimum. 10, 11, 12. I think.
Yes, I think we are. I think this position is good.
How many people would have
yeah,
missed
go
this
ahead.
ostium?
No,
And
I think
I
it's-
will be doing a standing exactly up to the ostium. I don't know whether these.
I think
The left
little
main?
longer up to
Are
the
you saying the
ostium would
left
have
main
been
ostium?
better. There is some plaque also there. Oh, I think
No, we had done the what you call IVAS, the left main body and wait,
Was in the ostium.
I think-
You have seen the LMC.
yeah.
I was.
Just give me.
I was in the LMC was totally free of disease.
Yeah, the LMCA body onwards. Can you show the LMCA, the body, this image, IVAS image on screen, please? Yeah, you can see that there's no disease in the left main beyond the mid part of the body.
So you are putting a stent into the LMC only for doing a pot, right?
No, there's a distal left main 67% plaque.
So there is actually osteoproximal part of the LMCA which is 3-4 millimeters. There is no disease. That is why you are actually avoiding a stent there.
There's a comment from
Yeah.
the floor.
Absolutely.
Please identify yourself.
Ramesh, no? Can you just give a mic to him? Okay.
Yes, I think.
Can use
Give
mine
me a
here.
boost, please. Yeah, I think you're good. Just give me a little bit of a. We have got 8 to 10 in the left main. Huh?
Yes.
It's an 18 stent. Huh? Half is 9. Right? Go, deploy. Huh? Go. Excellent. It's moved.
It's not it.
Your question is actually, can you just ask the question?
Sene, sir.
That's all.
Oh, where is a wire? The wire is not
go.
seen. No, it's a valid question. Actually, there is, can you, Sandhu, there is no wire in the circumflex?
14, 16, 16, sir.
Yeah, I normally don't put wires.
18 and down, sir.
18?
18.
Okay, down.
Down, sir.
Have you missed this thing?
No.
Huh? Very good.
Overlap.
Huh?
100% overlap.
So, yeah, somebody was asking about the wire in the circumflex. I usually don't put the wire in the circumflex. And because when you're doing the left main, it's usually not an issue to rewire.
I
Go
don't,
the overlap, please.
Sandhu, I
Okay,
think
can.
there is no problem in having a wire there. And number one, I was actually having some confusion. You planned for a tap, so I don't know why the wire is not there.
Yeah.
What was the rationale for removing the wire?
Yeah, I
didn't
think it's just a personal thing. I mean, I don't put the wires in the circumflex because I usually, unless it's a severe osteal disease of the circumflex, very tight, otherwise it's usually not an issue to wire it again. As such, you have to, even if you keep a wire, you have to wire the branch again. I know people say that it's easier to wire, it's a marker, but I agree sometimes in a diagonal or an OM, you can keep the wire, it's very tight. And But usually in a circumflex, I don't keep the wire.
But it may also help
take
you
a shot,
to
sir?
promote
give
the,
me the
te-
cord-
the,
cord-
the
cord-
pot
cordal, please.
appropriately, right?
Caudal, please.
Caudal.
Caudal, please. Okay. Give me the second wire, please. Okay. So as we see, the circumflex is flowing perfectly fine, and we can just wire it. And then, so can you show the circumflex IVUS measurements in the meantime while I'm wiring?
I think for the audience, I think there is no harm in keeping a wire there, and that will be saving you a lot of time. And actually,
Absolutely. No.
Basically for
There is no
experienced
harm.
operators
I
may,
agree.
may
I
not
agree.
require a wire because they can cross at any time.
Yeah,
But
yeah.
sometimes
There
you
is no
may
harm
lose the
in
ostium,
keeping.
even if
Yeah.
you feel that, or you don't lose the ostium,
Yeah.
but losing an ostium in a circumflex, and that's
Yeah.
a major
So I
vessel.
mean, it's actually
And
on a
recrossing
case-to-case
can be
basis.
much easier with the wire in
Uh,
place.
Yeah. If
Recrossing
yeah,
of the
if you
vessel
have a
with the
very
wire
severe
actually
osteal
as
disease,
the guideline, it is very, very good.
yes, I agree. So it's just a personal thing. I mean, if somebody wants to keep the wires, and it's always a safer bet.
Yeah.
We have an issue with a small early OM at the thing is going
I
there.
think, Sandhu, I have one more doubt. Why you did not do a pre-dilatation of the circumflex ostium before doing all these maneuvers in LMCA to LED stent?
Because there's not significant disease there.
There is a significant disease, no doubt about it.
Give me a torque, please.
Even angiographically significant disease.
Yeah.
So when you have a significant disease, a
So-
preparation of the osteal lesions, both circumflex
No,
and LED.
What is the IVUS?
So, I mean, we had seen that there is not much of an issue there of the ostium of the circ. That's why no pre-dilatation was done. So now we are in the circumflex. And just show me, I think in a small branch. Just show me.
I think a wire passing through this strut, a good operator can do all the time, but actually I'm telling you, by principle, better to have a pre-dilatation of the circumflex ostium. Number one, you should have a wire before when you put a stent into the LMCA. That is
Yeah.
actually needed.
Give me a small balloon. So I agree, I mean, to be on the safer side.
And
one
moreover,
should-
actually,
if there
when
is
you have
significant
a
disease in
preparation
the
of the lesion,
circumflex,
Sandhu, when you have a preparation of the lesion before putting the stent, then now actually you may be having a calcium plaque or calcium spur into the osteal part of the circumflex. Then after putting a wire
no,
through the stent
we had
strut
done the
down,
IVUS.
you'll
There
have
was
a
no
lot of
calcium at-
difficulties.
No, we had done the IVUS. There was no significant calcium at the circumflex ostium. And if there is not much of a disease, I would rather not pre-dilate and do everything after I have finally wired.
So
for
if you had a calcium there in the osteal part of the circumflex, you would have done a preparation of the lesion, right?
Oh, yes, definitely. Are we okay?
2.0
Just
balloon,
open the struts a bit. Yeah, go.
Going up, sir.
Now
That's
you took a 2.5 millimeter
Yeah.
balloon. What size of balloon you
This
have
was how much
taken?
balloon?
2.0.
Huh?
2.0.
This is a 2 millimeter balloon.
212.
And give me a 2.5 for the pre-dilatation of the lesion reach. Or we can do this also. Right. Yeah, we're good with that. Yeah, go. Go.
Going at high pressure, sir.
Yeah.
14 and 16.
14, 16. Yeah, down. So we're just pre-dilating the proximal circumflex lesion. And this is a 2 millimeter balloon. We'll just see whether we need another bigger balloon to do it.
Dr. Sandhu, when you prepare the lesion here in circumflex before during the tap stenting, we will go to the other lab and come back in 10 minutes. So by that time, you should tell what other things happen during this 10
Sure. We had left you soon after deploying the left main stent. And I had then wired the circumflex, then given a pre-dilatation with opened the struts of the left main stent with a 2 millimeter balloon, and then a pre-dilatation. But then the size of the vessel of the circumflex is 3 plus, so we took another balloon 2.5 and did another inflation to prepare the lesion. And then we took the stent, it's a 328 millimeter stent into the circumflex and a 3.5 balloon in the left main to LAD. And we did the tap procedure. Then after the tap, we did a kissing balloon. And then we saw that the ostium of the circumflex is a bit underexpanded. So we took a 4 millimeter balloon there and did another kissing at high inflation at 20 atmospheres. And then that's the result now. It's looking much better, the circumflex ostium. And now we are going to do a pot with a 510 balloon in the left main.
So this is on the circumflex wire or on the LED wire?
LED?
LED wire. This is the LED
Huh?
wire.
Yeah. So any comments on that?
Basically, now there is a strategy coming up in a tapped stenting. People avoid a pot. Basically, the pot will damage the weather because it is a
Yes, you can avoid a pot if you do a kissing balloon well into the proximal area.
Yeah.
And plus, I think it's a good strategy not to do the pot if your protrusion has been a bit too much inside the left main.
Correct. Will you do an IVAS to understand what is the final lumen area and all?
Yes, yes. After the pot, we will do the IVAS.
उल्टा हो गया सर.
Okay.
We change it. We put it on that.
So that's our 510 millimeter balloon for the pot. Yeah, I think we are good. Huh?
Yeah. Stent boost. You want to check?
Yeah, you just give a stent boost, please. It's not come properly. Just
Show
a
that,
little.
please.
Yeah. We're just doing a stent boost to check the position of the balloon.
Perfect.
I think we are absolutely fine. Yeah, go ahead.
Going, sir. I'm at 14,
14, 15, 16.
16.
Down.
What size of the balloon Sandhu you used? 4.5.
We used 5 into 10 millimeters. 5 into 10 millimeters.
Very good, very good.
Wires. Push the wire.
So we'll just do an IVAS. Please get the IVAS ready. We'll just do an IVAS run.
You have 3 minutes to go and you show the IVAS and then we have to go to the lectures. Please show the IVAS fast.
Okay, just give me the IVAS run, please, fast. LED.
LED, sir. This is
This
the
is LED.
This is
Yeah.
the LED. Can you wipe it, sir, please?
This is LED. No?
Yeah, this is the LED.
Yeah. Okay. Huh? Yeah. IVAS ready? Okay. We just take a run from the prox LED into the left main. Only. Okay. Ready?
Yeah.
Holding.
Holding, sir. The wire of circumflex.
So we're just taking in the IVAS and we just do a short run from the prox LED into the left main. Can you get it up, please?
Yeah, sure.
So I think that's good enough. Let's start and we go live on the IVAS screen, please.
Yeah, please.
Live on the IVAS?
Please.
Ready? Huh? So, so we are in the Prox LED stent. As you can see, the stent is well expanded. There is, now we are coming to the proximal LED. So that's the 4 millimeter stent here, which is showing perfectly, it's expanded well. And now we are about to come into the left main. There we are coming in. So you can see the ostial coverage is good. And here we see the left main stent. After we have done the port, it's well expanded in the left main. There is no malapposition or under expansion here. And once where we have finished, there is hardly any, there's no plaque or disease in the left main where we have finished also.
Okay. You want to do
Okay, good.
Good.
Finish.
You want to do a circumflex?
I think now what is the strategy, Sandhu? You will be taking another balloon to inflate?
No, I think we are done. The results of the IOS are good.
I think
We have, after the port, the left main is
Little under expansion in the ostial LAD.
Yes, I agree. A little bit in the ostial LED is there. I think we'll just do with a 4 millimeter balloon at high pressure in the ostial LED, kissing with the circumflex,
Good strategy, yeah.
like we did for the circumflex ostium, the other way around. So
Okay.
that's, I think we are just going to do the ostial proximal LED post dilatation.
But otherwise looks very nice. Congratulations.
Okay, Sandhu, congratulations from our side, and we are
Thank you.
actually leaving you. You just finished your work, and excellent work, and we are giving, please give a clap to Dr. Sandhu and the team. Thank you, Sandhu.
Thank you. All of you have a great day ahead. Thank you.
Thank you.